Mario decided to choose a fairly simple case for this session.
Yeah.
And Mario can carry on now. And I said thank you very much.
Okay. Thank you, Jacques. Federico is with us, and many other people. I cannot name everybody. So, just for the sake of sparing time, I will invite to present the case. Angelo, could you present the case? In the meantime, you think...
This is a 52-year-old woman who had a cardiac murmur detected in 2007 during a cardiovascular assessment for palpitation. On echo, performed in another center, a partial anomalous pulmonary venous drainage into coronary sinus was suspected, and further investigated were suggested, but she denied. 10 years later, she came back to the medical attention due to reduced exercise tolerance, and at that time a CT scan was performed and the suspicion of coronary fistula involving left coronary artery was made. And in 2017 was referred to our center for a diagnosis, confirmation and treatment. Currently she's complaining of dyspnea on effort, and on physical examination the body weight is around 60 kilos, she's fully saturated, and the continuous murmur is audible over all precordial area. The ECG at rest is pretty unremarkable, whereas the ECG on exercise test show ST depression at the peak exercise, significant ST depression, without symptoms with no chest pain. The chest X-ray show an enlargement of the third left arch on the left profile, and the transthoracic echo shows a significantly dilated coronary sinus with continuous flow into right atrium. The right coronary artery has normal origin and normal size. The left coronary artery has normal origin but is ectasic since the beginning. From the CT data, we managed to get a reconstruction, a 3D reconstruction. You can appreciate in purple the fistula, like several loop above the obtuse margin of the heart. The cardiac MRI showed good biventricular function, no delayed enhancement. And to get more details, we decided to perform a complete cardiac catheterization and angio as well. And the hemodynamic data showed slightly increased mean pulmonary artery pressure, normal RA pressure, QPQS increased, and a dominant right coronary artery with small collateral arteries supplying the left one. And then from the CT, we managed also to print out a 3D model.
Okay, can you see the printed model that
Yep.
was made
We can.
some days ago in my hands? Yes, you see the true coronaries and the very large tortuous fistula draining to the coronary sinus.
Yep.
Yeah?
Yeah, no, we can see it.
that?
We know it's a very beautiful picture. Has it helped with you crossing it?
This is it.
Well,
this is a device that we want to put in. I don't know what. Okay, so let's go back to our cath lab and see the what it did so far.
Great, thank you.
The first angiogram.
Oh, TUE.
Aki, you want to show or tell something about the echo pictures?
So,
Can we connect?
Stop.
Yeah.
Angelo did an
Can you
unbelievable...
see the echo now?
No.
Aki?
So
Possiamo vedere l'echo?
we need
Okay.
to show the echo.
Good afternoon. So we're going to take a look at the echo right now. Unbelievable study that Angelo did.
Sorry, Kevin.
Kevin, can you hear
Yeah.
Aki?
Can you hear Aki?
Yeah, no,
All right.
we can hear him fine.
Great.
Very
So this is a study that Angelo performed. And what you can see here, apical for equivalent apical for chamber view, and it's very clear that there is a significant flow going into the right atrium, most probably from a coronary sinus. So we aim a little bit more posterior. You see very nicely the mouth of the coronary sinus and increased flow into this region. Again, in another projection, we can easily see the large coronary sinus where our pointer is, and also with increased flow in this area. Here is, we can really appreciate all the loops of the coronary artery fistula. We also identify the left atrial appendage. Reconstruction of 3D really give us a very nice spatial resolution of the lesion itself. We're going to stop it right here, and what you can see here is the coronary sinus, SVC coming here, IVC there, and we can rotate it a little bit so everyone can see the SVC up, IVC down, and the large coronary sinus. And the last one, we practically can fillet and open both the right side. You can see the coronary sinus from the left side and from the right side. That's it, Mark.
Aki, do you know, can you tell us the size of the opening at all into the coronary sinus? Where the
We cannot demonstrate the opening to the coronary. Right. We can demonstrate the opening of the coronary sinus into the right atrium.
Right atrium. Okay. Yeah, which is, well, the main purpose.
Okay, so let's go through the angiogram.
So thank you very much, Aki. Let's go back to the angiogram, and let's, well, we have two arterial lines. We have a right internal jugular vein and right femoral vein. So that's the angiogram. Jacques, would you want to comment the angiogram?
Okay, well, this is LAO projection. There's a little bit of stenosis at the origin, but it's a relative stenosis because it's a very massively dilated snake-like coronary fistula. If we go back to the angiogram again, the first one, go back. First one.
Let's go.
Yeah.
Otherwise
and what? Yeah. So if you look at the bottom, where there's you can see the flow into the right atrium or coronary sinus right atrial junction there.
Yeah.
And the rest of the vessel is very tortuous and dilated. Okay, Mario, carry on.
Carry on. Next, the following. Yeah, we did a several angiogram when it was possible and relatively easy, I would say, to enter with a coronary wire this tortuous vessel up to the right atrial point, but that was the difficulty, to enter the wire through the entry site to the right heart. Next, let's go subsequently. Yeah, carry on. We tried to, yeah, here we go, the tortuous wire there. With the help of a microcatheter, we could advance a bit more, but it was very difficult to do that. And it was also difficult to enter the coronary sinus from the venous side, from the femoral vein, in spite of the help of the guiding or torquing catheter. But it was very, very difficult. So we decided, and Federico insisted on that, to go from right internal jugular vein, because usually it's much easier to enter the coronary sinus coming from the right internal jugular vein. You see the angiogram from the left coronary and the catheter advancing. The wire is inside the coronary sinus and the catheter eventually is in the coronary sinus. Then, while trying doing this, Jacques manipulating the catheter could enter the wire from the fistula to the right atrium. So next, carry on. So now we have this catheter there. Carry on, carry on. You see that's the snare. The coronary wire, which is snared from the venous catheter coming from the femoral vein. So very gently we could retrieve the catheter and establish in a circuit from the left coronary to the fistula and right atrium and the right femoral vein. Carry on. Okay, now we have a circuit. Yeah. Is that the last one? No, carry on.
Yeah, so that's the last.
Okay, so we have a circuit now from the fistula to the coronary sinus and femoral vein. We just have a 014
Yeah, so Kevin,
exchange wire.
even smaller. So the technical position is that we've got a circuit, but with a coronary wire 010, because the 014 was too stiff to get around all the curves. And so we've got a exteriorized 010 guide wire, and so we were trying to work out what our next step could be. You can notice on the fluoroscopy that we've got two Judkins in the coronary artery. There's a sheath, which is I think 12 French in the right atrium, and you can see the wire going all the way around through the sheath back out. So.
Jacques, I think we need some time to carry on for the first step. So if you agree, Kevin, we leave you now for a coffee break, and it will be back to you in, let's say, 20 minutes, something like this. Is that okay for you?
Yep. Okay. Perfect. Coffee for 20 minutes, and then we're back. So that's
right.
so that's 20. So that's half. We'll be back at half past 4 then.
Okay.
Great.
Thank you.
Okay.
Connect.
Thank you. They haven't got a plan.
Hello.
Yes, we can hear you.
Okay.
Okay.
So whilst you've been enjoying
describe it.
yourselves, having a break and talks, we've been struggling, and we'll go through the various bits of fluoroscopy to show you the various steps that we've needed.
Right. Okay, Jacques. We'll describe the two wires, coronary wires across it. Yeah.
Right, so having established a guide wire circuit, we couldn't get the deflectable sheath through, so then we used a second guide wire from the coronary artery side, arterial side, and snared it and established a wire circuit. Then we used a glide catheter from the venous side up into the fistula, and alongside the first coronary wire, we passed a second 018-inch V18 control wire, and snared that. And then with the two wires, with the guide wire circuit, we tried to push this tip deflectable sheath, and you can see eventually it popped through. This is we had to swap over to a flexor sheath, 8 French.
Yes.
And now you can see we've got a guide wire circuit and a flexor sheath, and here we were trying to take one of the guide wires out, which gave us less force really, and so the sheath has come back a little bit. But right
this
now,
is it. Stop it.
Yeah,
now we go live. Okay. So we decided to use a muscular VSD occluder, 10 millimeters.
On the last angiogram we did, we sort of, if we show the angiogram with the sheath, the last one before this.
Okay.
Let's
have a look at the last angiogram.
One before. Yeah, this one.
This one.
So I don't know if you can see, it's very difficult to work out how big a hole or opening it is into the coronary sinus right atrium, but you can just about see it at the top of the curve, and it's at least twice the diameter or the profile of this 8 French sheath. So we're working on the basis that this is about 6-7 millimeter or 8 millimeter opening at most, and so then we decided on this anatomy that we would go with a muscular VSD device, and we've decided, because of the sheath and the guide wire circuit, to go for a 10 millimeter muscular VSD device.
Federico, we have to flush a bit this.
Yeah, flush this.
Okay.
So that's currently, I think you can just see the live fluoro.
You see the fluoro live. The 014 wire is still in the sheet, but we will be able to advance the device. Jacques is advancing. Can you carry on? Yeah. Okay. You go to the tip or what?
Yeah, because it might jump back a bit.
That's
too
right.
much. So now we've got
and Selenia ready to do an angio when I ask you.
So now we've got the muscular VSD device just protruding a little bit out of the sheath, and I'll just try and get an onion made.
Shall we do an angio?
Yeah, about there.
Let's do an angio here. Selenia, inject.
Okay, so now we've got plenty of length. So
no, we
Yeah, the catheter's flicked out.
Yeah, that's, I reposition. Test. Okay, let's do a proper angio here. Selenia? A che pressione che
So we're, in terms of current position, the device is well into the arterial side of the fistula. So that's all looking good. Now just giving ourselves a little bit of space.
Shaq, it's very interesting.
Yeah.
Okay, Shaq.
Shaq, it's
Sorry, we can't hear you.
yeah, very interesting to see the course of your wire rail and the tortuosity of the fistula, although the wire is relatively straight now. True?
We've got a lot of tension on it. That's
Yes.
Okay.
And
I
would you
think,
consider using a guide for your angiographic catheter to maintain position? I noticed it kind of pops out.
Yeah. Yeah, no. I think at the moment we just want to try and get the device in place, and
Test
then
again.
then we'll sort it out. Yeah, but you're right.
Yeah, okay.
Yeah. So we're a long way in. So now we can start pulling back, Mario.
Yeah. Selenia, I'm pulling shock.
Yeah, and I'll keep a little sort of device slightly open, the disc. And it will jump, so you'll have to push forward.
Yes. Let's do a proper angio here. Selenia.
Yeah, so there's a while to go yet.
Dobbiamo avere un catetere migliore qua nella coronaria.
Catetere
O
guida.
lo tieni tu, sì.
Do you want to get a guide catheter or just carry on?
Well, I
Right.
try to keep it, yeah.
Okay, right. So,
So
now
let's
you'll have
carry
to
on.
keep coming back, Mario.
Yes. I'm pulling that.
Yeah.
Okay.
Okay, so now you'll have to be ready to, it'll jump in a second.
Ok, fai un test. Ancora.
Okay.
Ok, dai, vai, Selenia.
There. So we've got a little while to come back.
Yeah, I think it's gonna be on the column. Yeah.
Yeah.
I'm pulling shock, yeah.
Yeah. Carry on.
I'm pulling everything
And
there.
then just, yeah, keep coming. So ease up on this.
Let's do an angio here.
Yeah.
No more tension there.
Well, we need to have a proper catheter for injection. Let's change
Yeah.
quickly with the guiding catheter. Left jack is guiding catheter because it jumps out.
Yeah.
Yeah?
Yeah, I'll hold
Okay.
this. I'll hold.
Yeah.
Yeah.
Okay.
JL4, JL5.
CL5. Okay.
So just out of interest, just push the sheath in because it might lift upwards and then come back. Yeah, that's it. Okay. Right now you sort out. Yeah, so we're just swapping the Judkins left for a guide catheter. So at the moment we've got a little bit of time to ask or any questions. But it's a very, very challenging fistula. The ones that I really hate are the ones that drain to coronary sinus, largely because they are pretty much always huge and tortuous like a snake.
Okay, let's get the left jack
And it requires a lot of technical modifications, circuits. Trying to cross them is not always easy. Then you run out of length of wires and catheters. So there's a lot of mix and match sort of technology that we've been using here.
Okay. Let's carry on.
Yep. So that's a guide catheter coming in, is it?
Shaq, while you're...
Any other comments?
Yeah, can I ask you a question about the wires? Because the first one you crossed with was 010 coronary wire. What about some of the longer neuro wires that are meant to go through these tortuous vessels? Have you had success with those, or what's your go-to for this? I know this is a very unusual, difficult case.
Flash.
So most frequently I use an 014 coronary wire, the luge wire,
Test.
for all these
Let's
tortuous
do a
fistulas.
proper
Sorry,
angio here.
let's just carry on here. Sorry.
Yeah. Inject.
Okay, so
Okay.
here we need to push this from the arterial side so that it pushes the wire in a little bit more, and then pull back on the device.
Okay.
Yeah? Okay, then carry on, Mario.
Yeah. I'm pulling everything back.
Yeah.
But
There's a
it is
little-
not crystal clear where
And now
it's
pushing.
finishing.
Yeah.
Pushing.
So you just need to come back a little bit more. Move the table slightly headwards if you could.
Okay.
That's it, fine. That's fine. Okay, so now
Do another angel here.
we've got a little while to go yet.
Yeah.
You see, so it's the top aneurysm we need to come back to.
Yeah.
Yeah, so we have to pull
Should we-
back. Yeah, so we need to pull it back more.
I'm pulling.
Okay, otherwise I'll have to pull the device in a little bit to make an onion to let it pop through.
Well,
And
I think it's going to be easy to pull everything anyway.
Yeah, yeah.
Because it's too large.
yeah,
You do it this sharp because
so pull,
yeah.
it's pulling the aneurysm, isn't it?
Yeah.
Okay, so
Selenia,
now,
quick to do an angel here again.
yeah, so it's still in that aneurysm.
Still in the aneurysm. Yes.
So one of the possibilities could be, if we deploy the device here, because if it's in that aneurysm, just to see whether it locks it there or not.
Wow.
Hmm?
Let's advance this wire.
Oh, right, that's it.
Yeah.
Store that, store
Yeah.
that.
Stop. The movement was done just pushing the
easing on the
catheter
wire.
with the O14 wire,
So replay
relieving the tension.
Yeah.
Okay?
Replay
so
that
let's,
store fluoro.
Okay, let's see this.
Yeah.
So let's let
Yeah. It's free.
yeah.
Replay the
let's
previous
relieve-
store fluoro, Mario.
Okay.
Replay.
Let's have the Selenia.
Replay previous store fluoro.
L'ultimo, dai. Avanti l'ultimo.
Okay.
This is it.
Yeah, okay.
Okay.
So shall we do one more angio before we pull?
Yes, yes, we do a more angio. Yes. Inject.
Yeah. So that's now looking better in terms of position, because you can see the coronary sinus filling, which is on that descending limb of that Judkins left. Yeah? So
Yeah, but I don't see exactly where
the waist, the waist should be.
exit point is.
No. So I think
You have to
now
go a bit too more LAO, so
Yeah,
Yeah?
I have
You agree?
just a couple questions for you, Shaq and Mario. Where do you
Yeah.
think your landing waist is now, and could the entry to the CS be fenestrated?
this is exactly what we're trying to sort out.
yeah, we're trying to find out if we're near the landing area, but
Right.
fenestration, well, if there is, then I wouldn't worry about it too much. We're hoping that the discs will cover it. So shall we do an angio in that projection
Okay?
and then work out? I can see, yeah, the problem here is it's all superimposed. So I can see where the dilated coronary sinus is, and I can see where the disc is, and I think we're pretty much about the right area. Do you agree?
Yeah.
I mean, we can pull a little and see. Can you get better resolution or
Yeah.
those fluoro?
Vedi la risoluzione migliore possibile.
And I'm going to release the waist at this stage rather than the whole. Is that the best we can get?
Well, we can also do an angel from the
Sheath,
side
yeah.
out here.
Yeah, okay. So
You have it or not?
Yes.
Yeah. I
So
think
if you
it's
could
going to
do
be
that, yeah.
useful to do an injection aiming not from the left coronary, but through the side arm of the sheath.
Yeah.
Let's do it, Sharp.
Yeah.
So,
So if I
we
hold
can
the
understand
device.
a bit better. Yeah.
Yeah, let's see if we can get anything. Yeah, that's it. Okay, acquire. When you're ready.
Ready to go, Federico?
Yeah.
Yeah, it's going to be tight, isn't it?
Yeah, it's very tight.
Yeah. It's
Okay, so
difficult.
that's not. Okay, so I
that's
think
okay.
we've got to take a decision
So
about
we
deploying the waist and.
Pull a bit more
yeah,
or what?
yeah, yeah. Keep pulling. and then I'm going to push.
And keep pulling.
Yeah, hold it there.
So you
don't pull
deploy it
anymore.
there?
Yeah.
You want to deploy it
Yeah,
here?
we're doing on cine, so
Yeah.
we can see better shot. Now there is a waste there, you know. Okay.
Okay.
I suspect this is in the fistula.
So
We
can
have
I
to do an angio
contrast?
here.
Yeah. I do that first and then.
Dai.
Okay, so let me just do, I might be able to do an angio. Just fluoro for me.
Okay.
Fluoro?
Yeah, your live floor.
Yeah, I'm not getting enough contrast out of this.
No.
Flush.
And well, try to pull just to feel
Yeah.
some resistance.
Mm-hmm.
Yeah?
Yeah.
If you allow me to pull, yeah.
But we may be better off in the other projection, Mario. So
Okay.
less LAO.
Okay,
Less anyway.
let's move it.
Yeah,
There.
you can
Stop.
see the device better
Stop there, stop there. Dagli al centro e un ingrandimento ancora.
I think that looks more encouraging, doesn't it?
Let's do another angio in the coronary, Selenia. Let's go.
Yeah.
It looks like
What do you think?
in reasonably good position, isn't it?
Any thoughts from you guys in terms of position?
Well, your device appears to be stable. I'm trying to figure out how much it's going to impact this torrential flow so far, but obviously your ACT is probably 300 or something. Thoughts from the audience on this device position? Show of hands for who thinks this looks acceptable. Bill,
Pull the wire and see what's going on.
What, the other wire?
can we have the microphones?
Shaq, this is Bill Hellenbrand. Can Aki look and see if he can see the disc in the coronary sinus?
I think Aki's disappeared. He got fed up of waiting, and so he's gone. Has he gone, Aki? Yeah, he's gone. So
Well,
good
I wonder-
suggestion, but he's gone.
I wonder if you can see it.
I think Don has a comment.
So you would
Mario, I wondered, do you think there are two different connections from the same fistula to the coronary sinus?
I wonder.
That is a possibility,
Maybe.
but it's very difficult. From the TOE that we had, Aki thought there was only one opening on the color jet. So I don't know, and we'll never be able to answer that question, Don.
Oh, yeah, the
So we
coronary
need to take
sinus
this
has
wire out.
the only
Yes.
entrance that as it comes out on the TOE. But it looks in this angio that either it's a curvature of the vessel or there are two separate connections to the coronary sinus.
Yeah, now.
Could you now give some contrast to your sheath? The device is out, so you could do now the injection in the sheath.
Yeah, I've tried that. It's still all very tight. We'll try it again in a minute. We'll
Well,
just acquire it.
yeah.
Sini.
Yeah.
So, I mean,
think,
the device looks stable.
Jacques, we have to remove the coronary wire,
Wire,
and
yeah,
release the
next.
device.
Yeah.
Yeah?
Okay, so that's the next thing to do.
Yeah.
Move it this way.
I hold
which
the-
is the soft end.
The soft end is that, and this is the stiff
So we
end.
should go that way.
Okay.
So hold on, let me loosen this. Okay, go.
Close it completely
Yeah.
and remove the
Go on.
wire.
Yeah, so the wire needs to come out of that side.
Yeah?
Yeah.
Are you doing that?
Yeah, I'm trying to. Is it
But,
coming?
but
back?
I think you probably have to
No, no,
take
no,
this
no.
catheter out as well.
No, no, wait a second. It's fixed.
No,
Yeah.
yeah.
That's
So now
fine.
try
Okay,
it.
now it's.
And we can remove the catheter as well.
Yeah, there's no point in having that catheter, so it's all
So I'm
crumpled
removing
up.
the
Yeah.
catheter. And you remove everything, Federico.
Yeah, it takes just a little bit of time because
Yes.
I don't want to damage the aorta. So
With tension. Why
Is it
give
coming?
tension?
No,
here?
not from here.
it should be coming.
Yeah, but it's
No.
not. Okay.
Yeah, there is some tension.
Because it was tight or what?
It's tension, just.
Yeah. But we have to take it out anyway.
Yeah.
I'm pulling this. Yeah?
Yeah,
Keep
yeah,
going.
it's coming.
Well, it's not from here.
Okay.
Now, the tension is relieved.
Yeah, this is
Wait, wait. Okay.
Okay. Just carry on.
Yeah, but this wire is not going in. Okay.
No?
No. So it may be stretching.
You see
How
the
about
tension?
removing it from this?
Why don't you take from this
Yeah,
side?
let's try it.
From this side, Shark.
Okay.
Okay.
Fluoro.
Well, and I keep the sheet in position here.
No, it's not.
It's not moving.
No. No.
No.
So let's try to do this again.
Yeah.
So you're trying to retrieve your wire before the device is released, correct?
Correct. So why don't we put a catheter, glide catheter over this as far as we can, just to give us a little bit more.
Yeah, it's going to protect the aorta.
Yeah. Yeah, so we're just trying to remove the wire at the moment.
Is there just too much friction along the delivery cable in the sheath? Is that the issue, do you think?
Probably, yes.
You
But we don't want to take a chance on releasing the device and then being trapped.
The wire, yeah.
So somewhere that's... Yeah.
Is it stuck?
Somewhere. It's at the top, is it?
Yeah. It's just there, close to the...
Can you comment on perhaps why you chose muscular VSD as opposed to a AVP2?
It's the length. We thought the disc distance of being short between the muscular VSD device discs would be perhaps better suited to this anatomy than the AVP2. So at the moment, we're still having a problem with this.
Shaq, Mario.
Yeah.
Can you comment on what your device is doing right now?
Yeah, well, it's we're trying to pull on the wire, which is then advancing the catheter a little bit, but it's also distorting the device quite a bit, as you can see.
It's in the fistula, yes.
Which is in the fistula.
Do you think that the reason you've got a residual shunt is because there are multiple exit points, or is it that there's somewhere more proximal that's filling? And if it's multiple exit points, is the plan then to pack further back with coils, or how are you going to tackle it?
Well, I think if we can get the device secure, then we can worry about multiple exit points later, and then you can pack with coils proximal to it. But at the moment, we've got a technical problem with the wire, I think, wrapped around the VSD device there. So just come back a little bit further with the sheet.
In which case, I'll leave you alone and let you get on with it, Shaq.
That's pulling the whole fistula.
Yeah. You're pulling on
Okay, now we've freed some. Oh no, it's wrapping itself around, isn't it?
Let me do a plain acquisition just to see what's going on here.
Yeah,
it's maybe just distorting the whole fistula.
Distorting everything, you see.
As the wire
So this fluoro again. Yeah, it's there. And really, ideally, if we can get this catheter to follow further, which is not doing.
Okay.
Okay, that's going in a bit.
Is it?
I think it moved.
Yeah, it's moving.
Yeah,
it's coming.
I think
okay, great.
If you're moving.
Yeah. So a little bit of brute force is good.
Okay.
Let's do it on Cine.
It's a good job you gave me lunch earlier on, Mario.
No.
So now we need to get the wire out a bit more. It's gone in, hasn't it, from there?
Yeah.
So it just needs a little bit more pulling.
Now they've got it
So, Mario, let me pull the wire.
Yeah. I try to work you.
Okay.
Okay, so that's the wire free.
All right.
Oh, shit. Right,
Okay.
so now we need to do an engine
Yeah.
before deciding about release. Mario, when
You're ready, Selenia? Jack?
There's a lot of flow.
I'm not sure whether
Yeah,
the device
let's pull it back a little bit. Because it's distorted, isn't it?
yeah, probably it's totally in the fist.
There. Yeah. I felt a jump.
Inject.
Yeah.
I
felt a jump.
think we are more convinced that this is the proper position.
Yeah.
Shaq, what do you think?
Yeah, yeah. I felt a jump when I pulled it as well.
That's right.
Yeah.
I think, okay. Shall we release it?
Yeah, so I just need to push this up.
Shaq, would you put the sheath back all the way up before you release it?
Yeah, that's what I was just saying. Yeah, certainly.
Why don't you inject to the side arm of the sheet?
Now, yeah.
Contrasto.
Well, if you see in the lateral view, it's more promising than in AP view now.
Contrast, yeah.
So, Shaq, your device has now changed orientation 3 times. So, are you certain it's going to stay there?
I'm not, but a lot of it was contributed to by that wire. So we'll just do a check angio.
Right, no, but you changed here now since the wire was out. Because yeah, there you go.
That's the angio through the sheath.
You see in the lateral.
If you look at the lateral,
looks promising.
That looks
that
a better
looks
sort
much
of
better.
Orientation.
And
LAO
let's go to LAO Selenia and we do an angel from the corner. Okay, okay. A bit more, a bit more, a bit more. Okay, that's it. Okay, yeah.
Cannot tell on the AP.
Difficult to tell.
Is there an RAO projection which we could try?
Yeah, we can try an RAO as well. Flick a destra. Huh? Federico, what do you think?
It's difficult to say.
Yeah.
It's hard to tell what the device is. Sposta il tavolo, okay?
No, it's not gonna.
Bill, what do you think now?
Shaq, I tell you what Shaq,
yeah.
One question is what we discussed before. You got your sheath in the coronary sinus, and when we had a similar case, we abandoned the device and we put a covered stent in the coronary sinus to close the orifice. That would take care of the fact whether you had multiple holes or not. And if you're not confident to where this device is and you're already in the coronary sinus, might you consider using a covered stent in the coronary sinus?
I think we'd have to put a stent graft, won't we? Because this is such a big...
I don't know what the measurement was, Shaq. Whatever the measurement was, or if you had a 10 zig covered stent, you could possibly do it.
Yeah, I don't think we've got 10 zigs. So we'd have to get those custom made and...
I can't tell where that device is for sure.
Yeah, no. I'm thinking, Mario and I were just discussing from the lateral that we ought to release.
Sure where it is.
We don't know exactly where it is.
Because the overlapping of too many tortuous and dilated vessels, so it's difficult to tell.
Yeah. So what do you think, Mario?
I think we released. Let's go to AP here.
Yeah.
AP or slight LAO.
I think I'm just encouraged a little bit by the LAO projection, so I'm thinking that we ought to release it.
Centralo meglio. Shall we do a final angel and you release it or what?
See, on the if you just let me do the tug, so Mario, so do a cine. Yeah.
Okay.
That made the decision easy, didn't it?
There you go.
And that was a gentle pull.
That was you said you're going to do a gentle pull.
Yeah.
Let's do an angel on the corner.
Right, yeah.
Pronto?
Okay. So that made the decision easy.
Shaq, was that a Minnesota wiggle?
Yes. Catheter needs to go in.
If you go back to your coronary angio just before you did your right-sided injection there, although there may be more fenestrations, there was a restricted entry point that your sheath may be through. So is there still a potential opportunity?
Where the device went. Can you inject or what?
Hold on a second. Sorry,
I'm not
just
sure whether.
Just tell us. Sorry, say again.
Just there was a restriction of the contrast distal to the device before it entered the CS on your coronary angio. So could you just do another coronary angio here to see where your device is now, if there's an opportunity to still land it?
Yeah. That's what we're going to do.
Riduce un po' l'ingrandimento. Okay.
Bharat.
Okay. Let's do an angel here.
Yeah, hold on a second, Bharat. I think that's still
in the fistula.
No, I don't think. I don't think so. I think it's in the.
I'm not sure where. Well, paradoxically, we were not sure where the device was, but
so
maybe still in the fistula, but close to the true entry point. Make a magnet here.
Yeah. So, right, Bharat, you go ahead.
I still feel that you are in the fistula. Just as you made an angiogram.
Yeah, we were just, that's what I was just thinking on that angio.
My feeling is if you can take your sheath a little forward and make an angiogram through the sheath, maybe since you are closer to the exit, you may be able to get a little better picture.
All right, so let's do a contrast here.
Yeah, you have contrast there.
Yeah, it might have been in one of those bends that we were in, and now it's freed itself, but let's see.
Jacques, fill the sheet first, then we do an acquisition, please. I think, all right.
Okay, but it's going to need 10.
Is that okay?
Yeah, 10 contrast.
This should.
Okay. Ready?
Yeah. Well, yeah, it's hard to inject. Well, let's do an angio from the corner because it's hard to inject it. But well, I'm not sure.
It still seems as if both of your discs are within the fistula. So perhaps a different angle with the coronary angio. And if you recaptured the proximal disc, you may be able to pull back gently and see if it will stay with. Then you're closing an exit point. I think you're committed to closing one of the exit points now or abandoning the disc.
Why don't you try to recapture the waist
and then pull back,
and pull it.
Warrican.
All right.
We have a comment from Warrican.
Not a comment, but Shaq and Mario, is it possible to do echo now? I think it's easier. I'm not sure whether we can identify the spot of where we are, because angio looks pretty, unusual. I mean, and not understand very well, but echo may help.
Yeah, let's find Aki.
Let's do an angel here. Yeah, to say. Okay, Jack.
Yeah, so we can come back a little bit more.
Yes, you can. Yeah. Jacques, you feel the tension, keep the tension and deploy the rest of the disc, the rest of the device. I do it on cine so you can see it, otherwise it's difficult. Yeah? Can you do that for me?
Pulling now.
Yeah? Okay.
There's nobody else who can do TOE, is there?
Yeah, we can.
Well, just you see the 3D reconstruction.
Yeah.
Well, we have the overlapping here. Can you show us the overlay? Do you see that? Not yet.
No, not yet.
Not yet.
Yeah.
Yeah.
Angelo?
In the 3D reconstruction with the overlay, where the fistula is colored in green and the right atrium in, let's say, violet, well, the device looks like to be at the exit point or entry point in the right atrium.
Yep.
How about looking with a transesophageal echo? I mean, that could give us a help in evaluating the position of the device.
Well, I think the device was actually
in one of those folds.
The fistula.
Yeah.
When pulling everything went in the right spot.
Yeah.
Now we will have a look with
TOE.
TOE, ok? Alza un po', vai in AP così può muoversi. Ok. Sharp. I think he's in the right position.
Might be okay. Yeah.
I think he's in the right position.
Yeah.
And it was not before.
Before, yeah, that's
it was
right.
In the fistula.
We were in the folds.
In the fold, these bands, etc.
Yeah.
Yeah? Dai, aiutate il dottor Micheletti, ragazzi. Aiutate il dottor Micheletti, ragazzi.
Yeah, so
coraggio.
As I said right at the beginning, these are terrible fistulas that you have to deal with.
Jacques, do you think this is the orifice of the coronary sinus that you have the plug in?
Well, I hope so.
So you occlude the coronary sinus as well?
Oh no, it's the entry into the coronary sinus, but the coronary sinus is so big, I think, that
coronary sinus and right atrium.
Yeah, so this is somewhere in the junction between coronary sinus and right atrium. And if the disc is parallel to the wall, then the rest of the coronary sinus should continue to drain because it was quite big. We may not have shown you the coronary sinus angio at the beginning.
From the jugular vein, re-enter the coronary sinus.
Yeah.
Can you do that?
Yeah, sure.
Yeah, I think another, well, now we will have a look at the echo. Yes, can I have an echo on? Yes. Yeah? You see the echo now? Yes.
So, is it Angelo?
Yes, we see the echo.
Yes.
If you could, there was a 100-degree angle where the opening was seen. So if you could have a look at that.
And put the color on. Abbiamo bisogno di tele sterili qua. Yeah?
Okay.
Can you do that,
yeah, sure.
Federico?
Absolutely.
Un telo sterile. Okay.
Fabio?
No.
So Angelo, there was a coronary fistula view earlier on.
Okay.
That Aki showed.
Yeah.
Tienilo su. Sì, sì, va bene, va bene.
Yeah, it's difficult to tell, isn't it, on that, whether there's one opening or two, and whether that's flow through the device.
Yeah, it appears as if there's both, some through the device and some around the device, and whether that's another entry point is highly probable. So.
We're going to try and get into the coronary sinus from the neck. Flora. Yeah, that's PA, isn't it?
Yeah.
It appears there as if you have a jet around the device coming from posterior to anterior, superior, inferior, whatever you were looking at.
Yeah. Yeah.
Alza lo sfondo un attimo, Angelo. Ok. Stai usando un multipurpose?
Sì.
Vuoi che spostiamo il tavolo?
Sì, un po' di...
Vuoi andare in obliquo destro?
Sì, obliquo destro.
Ok, let's go to RAO.
E poi la doppia Ok, abbassali B. Non si vede niente da qua. Metti la doppia al fluoro.
Ok.
Abbassali B, non vedo niente. Un po', ok.
So Angelo, can you see the coronary sinus at all? Well, on echo.
While they're working on this, Bill, can I put you on the spot in terms of the covered stent for the CS? Did you have 3D roadmap for that ahead of time, or how did you select the stent and the length and plan your CS closure covering?
We went ahead and put a balloon in the CS, the size we needed, did a coronary angio and saw that the balloon would not be covering egress of coronary vessels into the coronary sinus, and then went ahead and put the stent in that location, cutting it to make the right length that we needed to cover. And we spent 2 days trying to close this fistula before we decided to use that technique. So I understand what they're going through, but we tried it twice before we went to that technique.
I've got a flight to catch later on, so I haven't got 2 days.
I might have to change your flight, Jack.
Yeah. Thanks.
Oh, we can send Bill over to give you some relief.
Yeah, yes, that's a good idea.
All I will say is these cases are incredibly humbling because it's so difficult to assess the anatomy.
Yeah.
Quelli di prima.
JR catheter, Judkins right.
Ok, vediamo le immagini.
Cosa vuoi fare?
No, le vecchie immagini con le angio. No, indietro. Metà esatto.
All'inizio quando mi ha messo lo giugulare, sai.
Very early on. So what do you think, Angelo, on TOE?
Ok, questa.
Ok.
Yeah.
In obliquo destra.
Shaq and Mario, this is Tom Fagan.
Yeah.
As you're continuing to work again here, are you comfortable with us staying with you, or should we let you work a little bit and get back to some lectures?
Well, we're comfortable with anything. It depends on your time. We're quite happy for the company. But if you're a bit behind time, then go for the lecture.
Coronary injection.
Come back to you.
I think we're
On
going to...
whom?
Yeah, once you get to a point, let us know. I think we're going to go back to hearing the lectures.
Yeah.